Thank you.
As always. Yeah. How are you, Liana? It's so good to see you.
Good to see you. I missed you. I saw Justin.
Happy Mother's Day, Liana.
Thank you. You too. You too.
Thank you. Yeah, I missed seeing you this time, but I promise you, you're my first person I want to see as soon as we're back this winter, okay?
Okay, perfect.
If you don't come and see us in Melbourne before then.
I would love that, but we'll see.
Okay. I mean, with all your free time and everything like that.
Yes. Anyway, but things are good.
Things are good. Yeah, we're actually right now in the United States dealing with some parental issues.
Okay.
Yeah. So, but Justin said he had a really good time catching up with you, and he was going to call me while he was in your office, but apparently, like, I just missed you. Like, he had just left, and I was trying to call just to say hi while you guys were together catching up.
Yeah.
So, how's everything with you? Everything good?
Everything good.
Yeah?
Moving along. Yep.
Hey, you never let me know if little Alexander liked his backpack that you brought him from
Oh,
Melbourne.
he loves it. He loves it. He loves it.
Perfect. Okay.
Yeah.
Excellent.
And I think we're getting people on the call. Awesome.
Yeah. It's populating with humans. Very exciting.
Yes.
And Liana, is your team presenting today?
Yes. Yes.
Okay.
Dr.
Perfect.
Roca is presenting today. Actually, he's presenting a couple of mutual cases. It's on colorectal liver met management from,
Okay.
a little bit out of the box cases that we have many out of the box cases, but it shows two examples.
Liana, this is just the standard OHSU week.
Yeah, sure.
Hi, Flavio. Good to see you.
Hello. Glad I was able to make it. Got out of the OR in time and even made it home.
Oh my goodness.
my
Wow. You're
God.
way ahead of Liana. Look at her sitting in her office.
I ran from clinic and I was telling Kim Liu, you better cover for me because I don't think I'll make it in time. But
listen, I already have the bottle of wine ready to go behind me as soon as this is done. So
yeah,
wish I was there with you.
yeah.
Actually, Liana, I'm going to go see your colleagues, Dr. Heyman, because Dr. Chu is visiting.
Oh yes.
It's like a Mayo reunion over there.
Yeah.
Hi, Prof. Morning.
Good morning. Hello.
Sorry,
How are
I'm
you?
1 minute late.
No worries, no worries. We're waiting for all the partners to join and then we'll get started.
Thank you, Prof. In the meantime, just to quick update you, for the trip, it will be Monday, and then the annual meeting, it will be Tuesday. The focus topic would be provided by the end of this month. So at least I kind of prelim update you first.
Fantastic. That sounds great. I have one question for the team in Thailand from every site. There was a request for the September session from our wound ostomy nurses to talk about quality of life for ostomets, and I just wanted to make sure that we capture what they want to hear. If I can get a little bit more objectives, like of what they want the presentation, that will be great. Dr. Wanapa, if I can have a little bit more detailed objectives, because they're asking me, and I said, you're right, it's a pretty big topic. If we can hone it down, and then they can be ready for the September meeting we have.
Okay. Yes. I will discuss with Kun Parani and communicate with other side on the main things they wish to hear and learn from you guys for September. So this one we get back to you.
Yes.
Within this month.
Yes.
Yes.
Yeah. And anytime, early summer is fine. It's just I want to make sure.
Yes, because we are worried that if we wait for too long, we forget, and then you don't have enough time to. I mean, the speaker will not have enough time to handle it. Anyway, Prof.
Should we
I
get,
would like,
yeah.
yes, I would like to ask for the permission from the speaker today to have it recorded, and then the doctor and the nurse who will not be able to attend can earn the CME from hearing the talk. This week is quite bad for raining. It has been heavy raining everywhere. So a number of people might get stuck in the traffic and so on. So I just let you know that this week is a bit what do you call it? Quite hard for people to
To be able to
to
attend. Yeah, no.
yes.
No. We totally understand. We totally understand. We can get started. If you think we have quorum, we can get started. I can introduce our speaker and then he can get started.
Yes, please, Prof. Yes.
Okay, so today we have the pleasure to have Dr. Roca speaking to us about management of colorectal liver mets. And he was asking me, we have a lot of stories that we share, a lot of patients we share together, but he chose two good challenging cases, I would say, two good challenging cases where we have been able to move the needle a little bit. So you all know Dr. Roca. He's the chief of surgical oncology and also the physician lead for the Night Cancer Institute. He is very funny and a great speaker. It's so much fun to work with. And he has been a great addition to our OHSU community. So Flavio, take it from here. And looking forward to the presentation.
All right. Well, thank you, Liana. Hopefully everybody can hear me okay.
Perfect.
Yes? Perfect. All right. Thumbs up. Okay, perfect. Let me just share my screen now so that, and let me know if you're getting the right view. Never know the sort of multi-screen.
We're seeing your screen. It's not in presenter view. It's if you want to put it now it's good. Yes.
Now it's good. Okay, perfect. All right, great. Well, again, thank you again, Liana, for the kind introduction. Hopefully, I'm hoping to have some discussion with these cases. Obviously, we manage them a certain way. Always eager to hear how folks might do it slightly differently. I'm glad to see that we have a couple other folks on. I see Kim, I see Nima, which is great to get the perspective from a different group. And like I said, please feel free to chime in with questions. I won't be able to see the chat, so if somebody can let us know, let me know. Okay.
I will manage it, Flavio.
Perfect. All right. So this is the first case. So and these are both cases that I've shared with Dr. Sikidis. So these are true cases made up. So 66-year-old woman saw us actually back in December of 22, had some left lower quadrant pain, had a CT that then demonstrated what looked like an exophytic mass, so 4.6 centimeters rectal mass, kind of upper rectum 12 centimeters, some adenopathy, multiple hepatic lesions. So because of the hepatic lesion, she had the biopsy that was done, and we kind of routinely send those for molecular analysis. So she was a pan wild type microsatellite stable, kind of a high CEA around 300 or so. And so this is all done on the outside. Had a PET CT, had a hypermetabolic rectosigmoid mass, again, lighting up with nodes, liver metastases, and also a left common iliac node. She had been treated with 8 cycles of FOLFIRINOX plus bevacizumab. She kind of finished those around mid-May, where she came to see us. So let me show you the presenting CT scan on the left, and then on the right is the PET scan, and it's going to scroll a couple of times so you can see there the liver, some, liver lesions kind of distributed throughout. And then as you get down to the pelvis, you'll see what we're talking about in the rectum. Lots of stuff in the mesorectum, and and then you'll see on the right there the lighting, where the PET scan's lighting up lesions, the iliac node, and then the primary. Oops. Okay. So she had a rectal MRI, which is sort of our standard protocol here. Then noted to have a T3CN positive node, extensive EMVI, and a long segment superior rectal tumor deposit. She did have the decrease in the colorectal liver mets, and there was no liver lesions at that time. Sorry, no lung lesions at that time. All right. So what would be, how would this case be approached perhaps in Thailand?
Dr. Vinita, you want to try answering?
I think we might go with like the stage. I mean, like simultaneously doing chemo and surgery, like doing liver resections. I think we might try that.
Would you sequence in radiation at this point to the pelvis after the chemotherapy?
I think we might start with like radiation, like radiation and chemotherapy, and then doing like the liver resections at the same time.
At the same time. Okay. And then maybe do the rectal resection afterwards.
Yeah,
Or do everything at the same time.
probably after, I think.
Got it. Well, since I know Kim wasn't involved, Kim, what do you think in this case?
Yeah, I've seen us do like short course radiation, the liver resection, and then do the wait. Is this rectal sigmoid or is it rectal?
It's rectal sigmoid. It was sort of thought to be around 12 centimeters or so, but long segment, kind of, some EMVI, some nodes.
Oh, I would wait on the rectal cancer, but I don't feel strongly about. I prefer the radiation sooner, so it gives it more time for them to respond. But with us before,
Yeah, we didn't have the choice, right? Because the patient was already sent after they had the chemotherapy done.
Yeah, then I would go to liver resection and worry about the radiation later.
Got it. Okay. So yeah, so we kind of felt the same way. She had a good response in the liver. So I took her to the operating room and did kind of what I kind of think of as sort of the colorectal metastases special. I just try to do some parenchymal sparing surgery. So I will look with the ultrasound, did a partial apopectomy for 2 lesions, did a wedge biopsy of another, and then did a microwave ablation to 3 other lesions that were smaller. So you can see there that, the idea here, at least in my mind, is to try to not burn any bridges and preserve as much, hepatic parenchyma as possible. And sure enough, on the pathology, she did have, all the tumors were still viable, although there was a lot of variability in how much viable tumor there was left. So there was some lesions that had 1% viable tumor, and the highest one had about 20% viable tumor in it. And all the margins, were negative at that point. So then I think we had decided at that point that, and Liana, maybe it's where you can chime in because you know this patient a little bit better on that end. So then we kind of staged it from the liver resection and then went to the rectal resection. And my understanding is it was somewhat of a challenging case. It was a laparoscopic converted to open low anterior. In fact, I think, Kim, you might have been called in for this case too. And I want to kind of go into some of the details there as far as what you encountered.
Yeah, I remember this case. So the tumor was still, or it felt pretty bulky, or everything felt pretty pretty large and big. And when we thought it would be a rectosigmoid, we realized that this is much, much lower than, or we did not appreciate exactly the length of the tumor. So I remember I went and I did almost a complete like TME in a way with very low and brought an ankylostomy. And I was very worried because when we had the bulkiness of the tumors, how large the tumor was, that needed radiation.
Yeah, and I think that was the reason also why you didn't think you should
I did
hook
not
her up at
connect
that
her
point.
at that time.
Right.
Yes.
Yeah. So, and sure enough, it was kind of a bulky tumor, 5 centimeters, T3. Interestingly, there was a lot more viability in the rectum than there was in the liver. So it's still about 85% viable. The margins were close, but negative. But interestingly, lymph nodes were all negative. So I always find this challenging when you see kind of an advanced tumor that's got negative lymph nodes, but positive liver mets. Although I guess the lymph nodes could have converted from being positive to negative with the chemotherapy. Um, but the thought was, as Dr. Sikidis described, that because this was, did not get preoperative radiation, which is typically our preference, that given what she saw in the operating room, she should maybe get adjuvant chemoradiation. I don't know, Nima, if you're on, can you talk to us about some of the pros and cons of pre versus post radiation?
Yeah, I mean, in this oligometastatic setting, I mean, minimal pre-op versus post-op data to look at, but the classic study is the German rectal cancer study comparing pre-op versus post-op, showing improved local regional control within the pelvis, improved sphincter sparing surgery. So it's kind of why we certainly defer to the pre-op treatments. I mean, for a T3 node negative but close margin cancer, I mean, I think the risks of pelvic recurrence for this patient are there, but not incredibly high, honestly. I mean, with 0 out of 12 lymph nodes, a close but negative margin. I honestly would be okay with not radiating this patient's pelvis, to tell you the truth.
Yeah, and then I'm assuming we might have, if we had done pre-op radiation, might have seen more of a response, right?
Yeah.
I mean, I think you always see a better primary tumor response with chemo as opposed to chemo alone, although we have seen some pretty dramatic complete responders with chemo alone.
Yeah. Yeah, I mean, the thing with T3 and 0, there's a difference between a clinical T3 and 0 and a pathologic T3 and 0. A clinical T3 and 0, there's data from Memorial that, and these are even in MRI stage patients, that your lymph node positivity rate can be 30 to 40%, even in a treated MRI negative T3 and 0 situation. But a pathologic T3 and 0 is a different situation and a more true representation of this patient's biology.
Well, interestingly, this was a clinical and positive, and the MRI suggested nodal disease, but then on the pathology it was negative. So, but it's always hard to know. Was it conversion or was it just the imaging was misleading? So unfortunately for this patient, well, fortunately she didn't have any pelvic recurrence, but shortly afterwards, she did get restaged about 3 months later and had a new liver lesion. So you can see there kind of high in segment 7, right at the takeoff of the right hepatic vein. And whoops, I moved over quickly. Sorry about that. There we go. Okay. So we decided to restart her some chemotherapy. So she had FOLFOX and Avastin before. She was, I mentioned to you, type. So we started FOLFIRI and Cetux for 5 cycles, had stable disease. And then we, presented her again at the tumor board to say, well, what's the best way to treat this very small but deep lesion? And so we had talked about a couple different options. So obviously, reoperation would be one, although that would be challenging. SBRT would be another one. And we ultimately settled on percutaneous microwave ablation. And so she did get that in kind of March of 2024. You can see where they put the needle in, and had the patient kind of propped up. Well, this had been, I don't know if Dima, you were involved in this discussion either, but I'm assuming this would have been more, maybe easier localized by radiation.
Yeah, no, this
is
is not a problem for us to localize and treat. One concern I have is the proximity to the vasculature there for that lesion and the heat sink with thermal ablation. So this would be a case that I would argue more strongly for SBRT than I typically do.
Yeah, and I think this is kind of the important thing for us is that we have everybody kind of at the table, which is nice at our tumor board because we do have all the representatives there. And I don't recall exactly why that we went this route because I have the same concern, as far as not getting adequate, heat to get to that area. So interestingly, she then had that treatment done, but then shortly afterwards had more lesions. And interestingly, these lesions were actually found elsewhere. So not really at the place of the ablation, not really at the place of the previous resections, but really kind of started multiplying new lesions in the liver. And if you actually then look at her CEA, you notice it went from 308 initially, came down nicely during surgery, and then started going back up again. So just curious now, what folks do. So you have a patient that's now recurred twice in the liver, on chemotherapy, off chemotherapy, seems to kind of blossom. We've kind of done a couple different local treatment modalities. What do folks think about how to manage this patient? Anybody
Dr.
from?
Ton, Dr. Ton,
Yes.
do you want to answer? No, I'm asking my colleague to answer. Yeah.
Okay, thank you. I think if we can remove or get off the tumor lesion at the liver, it's possible surveillance for the treatment. I think surveillance after we get the tumor at the liver out. However, I would like to ask you at the first step of this patient for the treatment, why didn't I would like to ask about if possible to use chemotherapy first before surgery for control liver metastatic disease at the first time is possible for this case.
Yeah, so the patient came to us already after 8 cycles of FOLFIRINOX actually, and bevacizumab. So had chemotherapy, was resected, then recurred in the liver, had chemotherapy again, had from FOLFOX to FOLFIRI, and then and cetuximab. So had basically 2 already first line, second line chemotherapy, and then continues to recur in the liver.
Yes. However, about the preoperative radiation before the surgery, how about the radiative treatment compared with the short course or concurrent chemoradiation that appropriate in this case? In your opinion, is short course or long course is better? In my opinion, I think long course is possible. If possible, appropriate because can shrink down the tumor. And about the EMBI, that positive may be useful for the long course CCRT. How about your opinion about this?
Yeah, so you're talking about to the primary though, right? Not to the liver.
Okay.
To the rectum, not radiation to the liver.
Okay. And
Yeah.
Until now.
Yeah,
until now.
no, but that's a good question. I mean, in fact, I think Dr. Liu kind of alluded that a little bit, that if we were going to do a simultaneous resection, sometimes we do a short course. But to my knowledge, and again, I'm not the expert here, is there strong evidence one way or the other, short course versus long course? I know that the traditional treatment is the long course, but I think there was at least one European trial looking at short course versus long course.
Yeah, the Star Trek study that compared long course versus short course was just reported at the European Society of Radiation Oncology like last week. And as far as clinical complete response rates, long course won out by like I think 15 or 20%, like 60 versus 40% or something like that, if I remember right. So more and more data is showing that long course is definitely more of a durable treatment for these patients if we can, logistically fit it into the schema. But again, short course is beneficial whenever you really want to minimize the amount of time that a patient is off of systemic therapy.
Yeah.
Good
Yes,
systemic.
sir. Thank you.
So I think there's also been, and maybe a little bit out of scope for this discussion, but I just saw a Nature paper that came out of the University of Chicago looking at radiation to the primary potentially causing growth of metastases. It was actually just published in Nature by Ralph Weitzelbaum and his group.
Oh, I'll have to look at that. I don't know about that one. I'll look it up. Thanks.
Yeah, I'll say it. I think they ended up calling, instead of the abscopal effect, the bad scopal effect.
Bad scopal. Uh-oh. Okay.
So, anyway, but no, that's a good question discussion. I think for this patient, I think our concern was that anytime she came off chemotherapy and had some kind of local therapy, she would sprout new liver metastases. And so the question for us was, can we provide a treatment that's going to keep treating the liver as a whole without compromising, without having to keep going in there and trying to resect lesions. So what we ended up doing then is I took her back to the operating room to actually clear out the new lesions. Oh, there you go. Aaron put it in the chat. And then resected the new lesions. It required hepatectomy segment 5 and 6, another wedge of segment 6, ablated 2 other lesions in segment 8. And I think this is where it was really helpful to our program to put in a hepatic artery infusion pump. And I know I've talked to this group about that before. And we do that, kind of at the same time as the liver resection, because then we can give the chemotherapy then straight to the liver in what we call kind of an adjuvant setting. I think what was most interesting and telling about this case is that when we then got the pathology back from this third time recurrence, this time the tumor had 80% viability and had a new KRAS G12D mutation. So if you recall, the original tumor was a wild type KRAS. So I think what probably happened in this case is that she did have some kind of mutation that sprouted, and that was driving the biology in this tumor. So it kind of speaks to trying to do repeat genetic analysis in these patients, especially these that are not behaving like you would expect them to do. So basically right now she's being maintained on FOLFIRI intravenously and then FUDR via the hepatic artery pump. So it's basically just a 5-FU derivative. Her CEA has now bottomed out to about 1.8, and she's got no evidence of recurrence in the liver or the pelvis. And recall that she had been referred for adjuvant chemoradiation, but actually because she kept recurring in the liver, never really had it. So I guess my question is it worth even addressing that at this point, or she's so far out? Probably we can say that we can declare victory, at least in the pelvis.
I would say that this is a good story for everything you described. I wouldn't want to do anything more.
Right. So I hope that, again, we're keeping a close eye on her liver function test because of the HAI therapy. I think that's something that I know we covered, well, at least when I gave that lecture, is that we have to keep a very close eye on the liver function test because of the bile duct toxicity of the drug. And so this is why when we give this therapy, we give it exclusively at OHSU, and we have the oncologists give both treatments so that there's no confusion. Any questions from our colleagues about the management or the treatment?
อาจารย์ any other อาจารย์ to ask Prof the question?
อาจารย์ครับ I'm Dr. Wood from Washington Hospital. Can you tell me about the schedule for the maintenance of FOLFIRI and FUDR via the pump?
Yeah.
How
pump,
often and how long that you plan?
Yeah, so the pump treatment is usually, the pump gets filled every 2 weeks, and then we sort of stagger that with the FOLFIRI IV. The IV, is really just to get some systemic control because we know she had metastatic disease, although the only active disease that she's been having the last couple of years is really just in the liver. So at some point, when we feel that the systemic extrahepatic disease is controlled, we'll stop the IV treatment and just keep the FUDR via the pump. I think the question is, when do you stop the FUDR? And so it's a good question. At some point, we may just say, okay, I think we can declare victory. It's really now only been just over, let's see, the last operation, if I can get this slide right, was on September. So it's been, about 6 months or so, or 9 months or so. So we may actually then kind of see, and then what we do is we pause the treatment. But the key thing about the HAI is that unlike a port, it can't go dry. So she still needs to come in and at least get filled with heparin every couple weeks. Because if the pump goes dry or if we remove it, there's not a chance to get the pump back. So it's really a one-time treatment. And we find that some patients, like to keep their pump and just come in and get it filled every once in a while. When they're off treatment, we can actually fill it with glycerin. So they can then go 6 weeks without a fill. And then some say, you know what, I want this out. I don't want to have a reminder of my cancer. But then we have to counsel them that if it comes back, then we can't put the pump back in.
Thank you.
Any other questions?
I just want to know about, do OHSU have like that electrochemotherapy treatment for like colorectal cancer with liver metastasis? Like you're doing radiation with chemotherapy at the same time. So it's like electrochemotherapy or ECT.
I am not
heard.
familiar with that. I don't know if Kim, Liana, or Nima, or Aaron familiar with that.
No, I don't know. I guess I'm not aware of any electrochemotherapy. That's a new one for me. I'll look it up.
Or Will, I see Will's on as well.
I don't know anything either.
Yeah.
And I just printed the article, but everything you're saying about radiation-induced anthraquinone drives tumor metastases. It's all in mice.
Yes.
Okay. Yeah. My biases about that, but I won't talk about that,
Oh, I didn't know you had an anti-rodent stance on things.
Everybody says study everything in rodents, and then I say you put it on humans, and it's a completely different story. Anyway, but
Anyway.
yeah, I don't know anything about electrochemotherapy, Dr. Vinita. I've never heard of the term. I don't know about it.
So yeah, so it looks like it's used on superficial cancers where you provide an electric pulse to destabilize the cell membrane and potentially increase the sensitivity to chemotherapy. I don't know if Will, of any clinical trials or anybody utilizing this approach. I gotta assume it's not ideal in a rectal cancer situation because it seems like you would need a superficial cancer for this.
Yeah, I haven't heard of this, but I mean, I wonder if it might be part of like the melanoma research or something like that. It would make more sense for something of that nature. That being said, it is we talk not infrequently about what was almost our spoon trial using electromagnetic radiation to liver cancers, HCC. So I do know it's an active area of research utilizing sort of pulse delivery of electromagnetic frequencies.
You're talking about the trans-tumor fields.
Yes.
So,
and HCC specifically, there's a device under investigation.
Oh, because I know that the same device was used, I think Nuvance is the company. It had data in glioblastomas and then in pancreas cancer.
Yeah, I know. There's
actually I think the pancreas cancer data, the PANOVA trial is going to be presented at ASCO next month. But I think that's different because that's passing EM fields, not a current.
Yeah. So no, I don't know of anything, especially in colorectal.
So Will, while we have you on, I know you have some pump patients. How long, these patients clear their liver disease, have had kind of a pump, how long do you end up treating them for?
It's a great question, and I think it's always a little bit of an open-ended question, as especially our patients who have been on treatment for a prolonged period, a year, and have we start having the discussion as to, well, do we stop and see what grows back? And I know these patients frequently go to a tumor board where we potentially get a PET scan, try to assess viability, and then we sort of give them a biologic test of time, 3 months off treatment, and see what happens. But I don't know if it's really very well defined right now. We do anticipate that they will recur. But yeah, it's very much patient dependent, and also how well they seem to be tolerating the pump therapy. I do think it's really interesting the point that you brought up, however, the treatment emergent KRAS G12D mutation. We've kind of recently circulated, and I just think it's worth bringing up here, the IMPROVE phase 2 trial that was just recently published looking at intermittent versus continuous panitumumab in the metastatic setting. So 4 months on, 4 months off of panitumumab combined with FOLFIRI. And it showed really a substantial progression-free survival benefit, like really impressive separation of the curves, which pushes the idea that the RAS wild-type tumors seem to have a survival benefit and kind of outgrow the KRAS mutated. So perhaps sort of withdrawing that growth stimulus may be a way to try to address that development of resistant disease.
Yeah, I've seen lots of these trials. This is sort of kind of the metronomic dosing,
Yeah,
right, of chemotherapy. I know that's been used in
the panitumumab
different.
specifically. Yeah.
Oh, okay. Yeah. Yeah, I mean, this is the question also when you sort of do the whole, also the switch things, right? You kind of go one regimen, the other regimen. I know you don't like to burn through multiple lines of therapy right away, but I wonder if what's the driver behind that?
Yeah.
Cool. All right. Well, I have another case to discuss, which also is a little bit out of the box, if there's no other questions. This is kind of a younger patient, 44 years old. Similar story with abdominal pain, bloody stools. You can see the CEA there, CT, again, with multiple liver lesions, and had another rectosigmoid lesion, this time at 15 centimeters, but definitely seemed more sigmoid than rectum. Again, pan wild type, microsatellite stable, no extrahepatic disease on PET scan. And this is her scan. Much bigger burden of liver lesions. Really very few segments that don't have any cancer in them. I think it was only segment 4A and segment 1 that didn't have any cancer in there. So she also had been started on chemotherapy on the outside, had 6 cycles of FOLFOX and bevacizumab. Her, pelvic symptoms, bleeding resolved, and she did have a restaging MRI then 3 months later in June that showed a good response to the treatment. We didn't know if we could get all the lesions out, so we did get what we get here at OHSU, which is an HAI-specific CT scan to look at the hepatic artery anatomy to really see if she'd be a candidate for a pump, because I didn't know if I was going to be able to take all those lesions out. And so here you'll see the angiogram on the right that shows that she's got a normal gastroduodenal artery, because that's what we need. This is where the catheter gets placed, and we need to make sure that it's going to go to the left and the right, so you're going to get equal perfusion, and that there's no aberrant vessels coming from other places, or otherwise the therapy is not effective. And so this was the HAI scan following the systemic therapy, and you can see that the lesions responded nicely, but still there's a significant number of them. Although if you were to look a little bit closer, you could see that perhaps the middle of the liver is an area where there's some spared parenchyma right here in the middle of the liver, right by the portal bifurcation, and then you start seeing some lesions there. So ask the question here: we get her to a hepatectomy, perhaps a 2-stage. Do we put a pump in? Do we do a 2-stage hepatectomy and put a pump in, or just continue chemotherapy? So again, I'll give it to our colleagues to see how they would manage this, or if there's another option that's not listed.
I think we might try like 2-stage hepatectomy with like putting like infusion pump at the same time. But we do not have like hepatic pump right now in Thailand.
Yeah.
So probably if on the current practice in Thailand right now, we might like starting chemotherapy first.
Yeah, so she had 6 cycles, so she had 3 months of chemotherapy with good response. Would you maybe continue and give more chemotherapy, make it a full 6 months of chemotherapy?
I might be, and then maybe consider like consulting surgeon to do like hepatectomy if possible.
Yeah, I think this is always the question for us is we like to see these patients early on, right? So ideally even before they start chemotherapy, because once they've gotten more than 6 months or 12 cycles, it gets very challenging to do complex liver resections because the liver becomes very steatotic. It becomes, you get the kind of the oxaliplatin sinusoidal syndrome. And so it really limits how much we can do. So this is something I stress with our community oncologists a lot, is that please, even if you think the patient's not resectable or has multiple lesions, number of lesions is not a contraindication to surgery. Just let us see them right away, and we can come up with a plan, and we'll work with you to determine kind of cycles of chemotherapy duration and when they could come to surgery. So I was a little optimistic with this 44-year-old. I wanted to be aggressive. And so what we ended up doing is we did plan for a 2-stage hepatectomy. So the first operation was done in August. So I did a left lateral sectionectomy, so took out segments 2 and 3. I then took out those bigger lesions that were lower down in segments 4B and 5. There was another lesion in segment 4B that I ablated. And the reason I did that is because I wanted to establish a remnant. And so I knew that the right side in segment 6 and 7 still had a lot of lesions. So I'm trying to preserve segment 4, segment 5, and segment 8 to kind of leave the middle of the liver intact. And, sure enough, on the pathology, again, had good response to chemotherapy, negative margins. And you can see here what the CT scan looked like after the initial operation. So again, there's still tumors on the right side. The left lateral section is gone, but you see that middle of the liver is relatively preserved. That big lesion there was ablated, so that's technically dead. And so run that by again, just to kind of show you what I was planning to establish as a remnant, because then I was going to go back and take out from there down and leave this portion here of the liver with this treated lesion there. But I was worried that there was not going to be enough liver left over. And so after she had the operation, I took her to the interventional radiology suite and had our colleagues in IR do a posterior section embolization. So you'll see there, they've injected glue into segments 6 and 7 to knock out the blood supply there to try to grow that middle of the liver. And they also put a catheter down the right hepatic vein to do a hepatic vein embolization. So that truly then, it's called total liver deprivation. It basically cuts off all the blood supply in or out to segments 6 and 7 in order to induce hypertrophy of that middle section of the liver. And so with that technique, in about 6 weeks, we were able to get a remnant that was about 65% of the total liver volume. So a really nice, healthy liver to do that. And so operation number 2 then was done in October, about 2 months later, taking out segments 6 and 7. 3 lesions that were there, about 20% viability. And then shortly afterwards, about a month afterwards, she then went with Dr. Sikidis to have the low anterior resection. Again, did not need radiation because it was sort of up high above the reflection. I guess the left ovary was somewhat involved, and that was taken out on block. I don't know if Leon, if you remember this case, if you have any insight to share about that operation.
No, this was a very different operation than the prior one. The tumor was not as bulky, and it was truly an upper rectal cancer versus the other one that we had to complete a TME. So we were able to do a partial mesorectal excision and do an anastomosis. It was really it was really good. It was really getting her to a point. I remember when they referred her to us as like, there is nothing more than chemotherapy that we can offer her. And we were able to start pushing it a little bit further and further every time.
Yeah, and she's again, she has age and health on her side, so we wanted to be very aggressive with her. Interestingly, she did have some positive lymph nodes. Margins were widely negative here. And so this is, unfortunately though, after her operation, we were going to get her back on to finish off some chemotherapy. And of course, we got a CT scan at the end of December that showed 3 new liver lesions, not where the resection margins were. So that's the ablation cavity. There's 1 lesion, there's 2 lesions. And you can see what she's left with now is really just the middle of the liver. So you can see there's 1 vein. It's just the middle vein that's there. There's the right and left portal veins. And you can see these lesions were kind of deep. There's 1 right there, 1 down there. And I think the 3rd lesion was there. So you can see that those were not at the resection sites. They were not at the ablation sites. Truly, again, systemic disease. Obviously, the patient was very disappointed after undergoing 3 operations. But what would you recommend at this point? These are the options that we had on the table. And recall, she's had 3 operations. All she has is the middle of the liver left. I'll leave it open to the floor.
I think we can do like the hepatic artery pump to focus on the local control.
Yeah, so that certainly was one option that we had talked about extensively, and I was kind of pushing her in that direction a bit, just like the last case, because it almost seemed like we do all this local therapy. Once she gets off chemotherapy, they recur in the liver again. She was a little bit further away, we're worried about the travel back and forth. And so we had talked about, again, could we ablate these or radiate these? I don't know if Aaron or Nima, I can go back and show you the scan if you love, if that's something that you think could be feasible for her. That's the ablation cavity, but there, small lesion, another small lesion there.
Yeah, I mean, the scenarios where we tend to shy away from radiation SBRT, they're especially for metastatic patients that have tumors that are radioresistant, more radioresistant than primary liver cancers, are scenarios where we're touching bowel, near duodenum. You know, we need, I don't know, somewhere around 5 millimeters to a centimeter breathing room between bowel and tumor for us to feel comfortable with our ablative doses for colorectal metastases. So for this patient, I feel confident that this could happen safely. For primary liver cancer patients, we tend to be a little bit cautious in the hilum of the liver due to worry about biliary stricture. There really are not many series that show that patients with colorectal metastases are at risk of biliary stricture as patients with HCC are. So we tend to be a little bit more aggressive and ablative in the hilum for colorectal metastases than we are for HCC.
Yeah, and I think that was, for 3 lesions, these are a little bit challenging for ablation. And again, the thought was always, gosh, does it become a game of whack-a-mole? You keep treating lesions and then they just kind of start sprouting up again. So this was an interesting situation where she actually, resumed chemotherapy. had finished FOLFOX and kind of got FOLFIRI. She's really interested in a liver transplant. And so this is something that's become more readily available in the United States, especially since the TransMet trial that was presented at ASCO last year by they actually randomized patients with unresectable liver metastases to chemotherapy alone or chemotherapy with transplant, with, again, in a somewhat selected group, showing a benefit in the transplant group. And so there's a very active program. We don't have one at OHSU yet, but at the University of Rochester in New York. So she did a transplant from a friend, living related, in November of 2023. And interestingly, they get placed on immunosuppression. And I think what's been interesting to find in this series of patients is that, there hasn't been a lot of necessarily liver recurrences, but there's almost universal lung recurrences for these patients. And so she, about a year afterwards, developed 4 lung nodules that were hot on PET. They looked very suspicious for lung metastases. And so she's actually, I think she might have seen our radiation group, but then also saw thoracic surgery, and is actually in the works to have these lesions resected later this month. So again, I don't know. I don't think this is quite in Thailand. Are you guys doing liver transplants for metastatic colon cancer?
No, I don't think so. I don't think so right now. And we do not have like living donor right now, so we just do only for cadaver or like brain dead patients.
Yeah, I think some of these programs that do, I think they're mostly the ones that are able to do it, because we don't have living donor either at OHSU. I think in order to do the planning and the organ allocation, it really has to be a living donor for these kinds of, I guess I used to call it experimental, but we actually have a trial that shows benefit here. I think it's, the right patient. And I think, somebody who's young and has what appear to be liver limited disease. We did what we could to the liver. There really wasn't much more that I could take out. And again, the worry was that even if we, spot treated those lesions, she was still going to, that liver was seeded somehow, right? With perhaps microscopic tumor cells. So once the primary is out, getting a new liver in some ways makes sense, because then you really feel like there's not, disease. Although she did sprout these lung nodules. So you can, the only question in my mind is, were those lung nodules there before and they were just too small? Did the immunosuppression somehow, cause them to blossom? Because theoretically, she shouldn't have had any other disease outside the liver. So these are kind of interesting questions that I'm not sure we'll ever know the answer of. But as we get more experience with these liver transplants, we'll hopefully get at that answer. But at least the short experience is that these patients, even though they don't necessarily recur in the liver, they almost always recur in the lung. And so I don't know if there's some immune environment that allows for that to happen. The good news is the lung lesions are typically, easier to treat, if you will, in the sense that, you're not necessarily dying of lung disease. It's funny, it'd be worse, I think, if patients would be, recurring with peritoneal disease, because we know that can be a very challenging thing to treat. So I don't know if there's any questions on this case or on the management, or if anybody would do anything differently.
Can I ask one question? Yeah,
sure.
Did the patient receive any like a chemotherapy after liver transplant, or
She did resume chemotherapy. Yeah, sorry, that was all done at Rochester, so I don't have a lot of that data. But then, the problem is they're also on the immunosuppression. They really can't stop the immunosuppression, but at some point you have to stop the chemotherapy. And so I think that's the challenge at this point. So she did once these lung lesions came back, she did resume chemotherapy. But the hope is if they can get them out with surgery, then she can again not have to be on chemotherapy and just hopefully, at some point, if there's enough immune tolerance, the big question is, could she stop the immunosuppression?
Because we don't have the patient with the liver transplant after with the so we don't know about what is the chemotherapy that the patient should receive after the transplantation. Can anybody share the experience?
Yeah, it's a good question. Will, I know we don't have it, but do you know what's been done kind of around the country since the whole TransMed trial came about?
Yeah, no, I really don't have any experience to share on that. I'd be curious a little bit to ask some colleagues. I really don't know. My guess is that it's standing to keeping in line with standard like cytotoxic, but the usual suspects.
Yeah, so our experience again is we've had probably, I don't know, full of patients that we sent for transplant. Usually they either go to Rochester or Washington University in St. Louis also has a very active program. Those are the two we tend to work with the most. But the way we kind of think about it is that we like to use it, as really the end common pathway, right? So if we can resect them, we resect them. If we can't resect them, we put a pump in. If they start failing the pump, we kind of see transplant as sort of the last option, if you will. This particular patient didn't want a pump because it was worried about the travel associated with it. So she could have had it, but she just kind of went straight to transplant. In the TransMed trial, the argument there is that maybe transplant should be moved up in the treatment paradigm. At least that's what the authors were trying to acknowledge. And I know that there was a lot of excitement at ASCO when that happened, and there was going to be this big uptick of patients going, getting 6 months of chemotherapy or 3 months of chemotherapy and then going straight to transplant. But I don't know if that's really happened, in the US nationwide. And the other question that's come up sometimes when I talk to my transplant colleagues, they say that a transplant after HAI pump is more difficult because the artery is somewhat damaged from the chemotherapy, the intra. Although I have others that say that it's not any more difficult than a regular transplant. So we really don't know where we should put transplant on the treatment algorithm.
Professor, may I ask two questions? Don't
Yes.
you concern about after the transplantation, the immune suppressive drug will make the cancer flare up? And the second question, in Thailand, we don't have the hepatic artery pump up. We have some local treatment like the proton therapy. We may consult the proton therapy for this case.
Yeah, it's a good question. We don't have protons at OHSU. I don't know that there's a lot of data for protons in colorectal liver mets. I'd have to defer to Aaron or Nima on that one.
Sorry, I missed it, Flavio. What was the question?
Yeah.
Protons.
Okay.
Protons can be really helpful for some liver mets because you can really reduce the volume of liver that is getting treated. So especially if the lesions are sort of peripheral, then you're only getting entrance dose. And so I think when you have larger lesions or repeated treatments and you're starting to worry about the amount of functional liver you have left, protons can be really helpful. In terms of efficacy, there's no difference.
And then the other question was about the immunosuppression. Are you not worried?
Yeah, that's the tougher one. I mean, I'm not a transplant surgeon. I'm not a hepatologist. My understanding is that, you don't want to lose the graft, but at some point, can you back down on the immunosuppression? I mean, I think this is a challenge where we see in the other population where we're thinking about doing transplant, which is cholangiocarcinoma, which I know is pretty prevalent in Thailand. But also, I'm assuming patients aren't getting transplanted for those because the standard of care chemotherapy has actually got immunotherapy. So you're revving up the immune system. And so that's perhaps even worse for getting a patient getting a transplant. But did I misspeak? Are you guys doing transplants for intrahepatic cholangiocarcinoma in Thailand?
I don't think so. I think like we have like much burden for liver disease on that one, like
Yeah.
cirrhosis, decompensated, or even like hepatocellular carcinoma. And also we
Yeah.
don't have enough liver. So no cancer for now. At least they're proof that they're free for cancer. So there may be like some indication to know that you're free from cancer at least 6 months. Let's say that you have like other cancer. Let's say like you have colorectal cancer, but no liver metastasis, and then you have decompensated cirrhosis. So you might have to free from like cancer at least like 6 months or maybe a year to be a candidate and waiting list for liver transplant. So I think based on my experience, I don't see any patients have like cholangiocarcinoma and underwent like liver transplant in Thailand.
Yeah, so it's definitely very much an debate here in the U.S. There's a couple programs that are very active. In Houston Methodist, for example, has probably done the most of these. They've done about 60 liver transplants for intrahepatic cholangiocarcinoma, mostly living related, again, because of the timing of things. But there is a movement through our organ allocation system, UNOS, where they're now going to allocate points, but they're very restrictive. So the tumor has to be 3 centimeters, unifocal, which those aren't the patients that usually need a transplant. So unless they have a bad liver. So we are starting our program here with Dr. Enesved, but we have not enrolled any patients in that yet. Well, that's all I had. I know we're at time. I don't want to keep people longer than they need to, but happy to stick around if there's any questions or if there's any other thoughts.
Any final question from you guys before we finish? Okay, thank you very much, Prof, for the 2 cases. Enlighten us a lot, and we hope to see you again. Thank you.
Likewise, thank you. Thank you for having me.
Thank you very much, Dr. Roca. Those were excellent cases. Thank you. Great to see you, Liana.
Thank you.
Thank you,
Great to see you, Leah.
Bye-bye.
Thank you.
Thank you all.
Swadika.
See you in 1 month. Bye-bye.
Bye-bye.